So this crumpled tissue paper appearance of cytoplasm, crumpled tissue paper appearance, or it is also called wrinkled paper appearance of cytoplasm, that is seen in something known as Gaucher cell. Hello friends, in this video we will be discussing the latest questions, the recalled questions of NEET PG 2021 that came from pediatrics. There were almost 20 questions that I could get by the recall of you and your friends. There were almost 20 questions from pediatrics. The questions were clinically oriented, but they were pretty simple and straightforward. So I'm sure if you've gone through all the videos and the previous year's questions nicely, you would have been able to solve most of them. So out of 20 questions, almost 18 to 19 questions are directly from what we've discussed in all our videos. Okay. So we'll be going through these questions once again so that you can, consolidate it and revise these topics, which are very important ones. All right. So let's start. So the first question, an Anganwadi worker takes the weight and height of a 4-year-old child and she finds out that her height for age is less than -2 SD. So height for age is less than -2 SD. The likely causes. Now, if the height for age is less than -2 standard deviations, we call it stunting. Okay. And stunting is an indicator of chronic or long-standing malnutrition. Okay. So chronic undernutrition is the correct answer. So as per the WHO definition, if the height for age, so according to the WHO definition, if the height for age is between -2 to -3 z-score or standard deviations, or between 85 to 89% of expected, then we call it stunting. Okay, stunting. Right? While if the height for age is less than -3 standard deviations or z-score, or if it is less than 85% of expected, then we call it severe stunting. Okay? And stunting always indicates chronic or long-standing malnutrition, because for the height to get affected, the malnutrition has to persist for a long time. Only then you can see the effect on height. Okay? While wasting or decrease in weight for height is an indicator of acute malnutrition. Okay? So, height for age less than -2 SD indicates chronic undernutrition. It does not indicate acute malnutrition, which would be indicated by wasting or decrease in weight for height. And recent infections would also mainly affect the weight of the child and not the height. Okay? So, pretty straightforward question. Moving ahead, a 16-month-old boy whose weight is 8 kg is brought to the clinic by his mother, and the image of the growth chart was given here. So, what do you note here is a 16-month-old child and his weight is 8 kg. So, first we have to interpret whether this is normal or not, and then we can answer this question. So, just remember 16 months of age and 8 kgs. Now, let us plot it on the growth chart and see. So, 16 months of age and 8 kgs. So, you can see on the x-axis you have the age. So, this is 16 months and 8 kgs is here. Right? So, let us draw it and see. 8 kgs. Okay? And 16 months. So, let's draw the 16 months and see where it is crossing. Right? So, you can see where is it falling? So, it is falling here. That means between the -2 and -3 z-score lines. Okay? And this is a chart where you have weight for age. So, the weight for age of this child is between -2 to -3 z-scores or standard deviations. So, this will indicate acute undernutrition or moderate undernutrition rather. Okay, moderate undernutrition. So, weight for age between -2 to -3 standard deviations or z-score would indicate moderate undernutrition. While if it is less than -3 z-score, so if it is falling anywhere below this line, below this black line, if it is falling anywhere below the black line that you see here, then it will be severe undernutrition. Okay. So in this case, as it is falling between the -2 to -3 Z-score lines, so it is moderate undernutrition. Now let us go through the options. So one of the options is child is healthy, no advice. No, this child is not healthy, he has moderate undernutrition. Severely malnourished child, refer. This is not a severely malnourished child because it is between -2 and -3, not less than -3 Z-score. Severely malnourished, advise mother for home-based care. Again, it is not severely malnourished. Moderately malnourished, advise mother to feed calorie-dense food. So this is the best answer out of the given options. Okay. So moving on to the next question. A 10-year child presented with webbed neck. Okay, so webbed neck is there. Low posterior hairline, shield-shaped chest, short stature and swollen feet. All these are features of a very important syndrome, that is Turner syndrome, where the karyotype shows 45XO. That means there are 45 chromosomes instead of 46 and there is a single X chromosome, no Y chromosome. That means it is always seen in girls, never seen in boys. Okay. And USG abdomen shows small uterus and streak gonads. They are also what is classically seen in Turner syndrome. There is hypogonadism, right? So the diagnosis here is not Edward, not Klinefelter. Edward we know is trisomy 18. Klinefelter is 47. XXY. Turner syndrome, yes, 45XO, and this is not Down syndrome. In Down syndrome, you do not get these clinical features. You get typical facial features and things like sandal gap, then your simian crease, clinodactyly and so on. Okay. Now the important clinical features of Turner syndrome you can remember by a mnemonic. So the mnemonic for Turner syndrome is see a baby clown. Okay. So S for short stature, and they also have sensory neural hearing loss and short fourth metacarpal. Okay. Right. A for amenorrhea. There is primary amenorrhea in Turner syndrome. That means because the gonads are not well developed, these children never attain menarche. These females never attain menarche. Okay. With B, bar body absent. You know, number of bar bodies normally is number of X chromosomes minus 1. So normally females have 2 X chromosomes. So 2 minus 1, that is 1 bar body. But Turner syndrome, only 1 X chromosome is there. So 1 minus 1 is 0. So a female having no bar body, think of Turner syndrome. Okay. Then C for congenital heart diseases. So the most important or most common congenital heart disease in Turner syndrome is bicuspid aortic valve followed by coarctation of aorta. And another C is for cystic hygroma. Cystic hygroma is also common in these children, okay, of Turner syndrome. L for lymphedema and low thyroid. Lymphedema, edema of hands and feet is common in these children, and low thyroid or hypothyroidism is again quite common in them. Okay. O for ovaries are underdeveloped. So you have streak ovaries and rudimentary uterus. Ovaries underdeveloped. Okay. W for webbed neck, and N for nipples widely spaced. So they have a shield shaped chest with widely spaced nipples. So nipples widely spaced, and another N, you can remember another thing with N, that is they have normal intelligence or IQ. So these individuals have short stature, they have amenorrhea, they are infertile, okay, but they have normal intelligence or IQ, right? So that is 45XO or Turner syndrome. Moving on to the next question, a patient presented with anemia, bone pain and hepatosplenomegaly. Biopsy of the bone marrow was taken and the result is shown here. Okay. So your question is, what's the enzyme defect? So what you see in the biopsy here is this cell, this abnormal cell with the appearance of the cytoplasm as if you've crumpled a tissue paper or wrinkled a paper. So this crumpled tissue paper appearance of cytoplasm, crumpled tissue paper appearance, or it is also called wrinkled paper appearance of cytoplasm, that is seen in something known as Gaucher cell, okay, due to the accumulation of glucocerebrosides, okay, because the enzyme glucocerebrosidase is deficient in Gaucher disease. So the enzyme deficient here is glucocerebrosidase, okay, and glucocerebroside accumulates in the cytoplasm of the cells, giving the appearance of a crumpled paper appearance, crumpled tissue paper appearance, or wrinkled paper appearance of the cytoplasm. And because Gaucher cell infiltrates the bone marrow, you get pancytopenia. It infiltrates the liver and spleen, so you can get massive splenomegaly and splenohepatomegaly. There can be bone pains. There may or may not be neurological features. Okay. Glucose 6-phosphatase, we know it is deficient in von Guericke disease, not in Gaucher disease. Hexosaminidase A in Tay-Sachs disease, and iduronate sulfate sulfatase in Hunter disease. Okay. Moving ahead, a female child has recurrent candidiasis and respiratory infection. Take it again. So, a female child has recurrent candidiasis and respiratory infections since she was 3 months old. Now, immunodeficiency workup is being considered. Okay, so recurrent infections are there, fungal infections and other respiratory infections. So, you are suspecting immunodeficiency. Which vaccine is contraindicated? So, in any individual where you are considering immunodeficiency, you do not give live vaccines. Okay, so TT can be given, it is a toxoid. Okay, measles MMR, it is a live vaccine, it should not be given. So, this vaccine is contraindicated. DPT can be given. Okay, risk versus benefit. And killed IPV again can be given, right? Moving ahead, a 10-year-old schoolboy has presented to you. Moving ahead, a 10-year-old schoolboy has presented to you for vaccination. Which of the following vaccines are to be given in this child? So, BCG, you know, is to be given at birth and is not given beyond 1 year of age, even if the child has not received it, as per the National Immunization Schedule. Rabies vaccine, you do not routinely give it. It is usually given as a post-exposure prophylaxis only. Sometimes in high-risk situations, you may give it as a pre-exposure prophylaxis. Typhoid vaccine, again, as such, not indicated at 10 years of age, though it may be given, okay, if indicated. But TD vaccine can be given. So, a tetanus, TT or TD, tetanus containing vaccine can be given at 10 years and 16 years of age. So, that is the best answer. So, let us quickly go through the National Immunization Schedule, the latest one which is being followed. So, for infants, that means children less than 1 year of age, you can see at birth you give BCG, and at birth you give a hepatitis B birth dose and OPV 0 dose. So, at birth you are going to give BCG, hepatitis B birth dose and OPV 0 dose. Then you have OPV 1, 2, 3 at 6, 10 and 14 weeks. You have pentavalent 1, 2, 3 again at 6, 10 and 14 weeks. This pentavalent contains diphtheria, tetanus, pertussis, hepatitis B and Hib, okay, Haemophilus influenzae. Now then, fractional IPV is recommended to be given at 6 and 14 weeks of age, and rotavirus vaccine at 6, 10 and 14 weeks age, okay. Moving ahead, we also have pneumococcal conjugate vaccine which is to be given. This is newly introduced in the National Immunization Schedule and you should know when it should be given. So, it is to be given at 6 weeks, 14 weeks and at 9 completed months, okay, along with the MR vaccine, okay. Measles rubella vaccine again at 9 completed months to 12 months of age we give it. Japanese encephalitis only to be given in the endemic districts, and vitamin A first mega dose to be given at 9 months of age, 1 lakh international units. Now, for children beyond 1 year of age, what all to give? So, DPT booster is to be given between 16 to 24 months of age. MR second dose again between 16 to 24 months of age along with the OPV booster. Japanese encephalitis in endemic districts only. Vitamin A, again you will give mega doses at 6 monthly intervals till 5 years of age. Okay. DPT booster 2 at 5 to 6 years. And TT or TD can be given at 10 years and 16 years of age. So, a tetanus toxoid containing vaccine at 10 years and 16 years of age is recommended as per the National Immunization Schedule. It is also recommended for pregnant women, tetanus toxoid. Okay. Moving ahead, a child with HIV presents with features of pneumonia. Okay. So, a child with HIV presents with features of pneumonia. Which of the following organisms would be most commonly responsible? So, we've already discussed in the pediatric respiratory system, the most common cause of pneumonia in children as such is Streptococcus pneumoniae. But in a child with HIV, the most common cause of pneumonia is Pneumocystis jirovecii, which was previously known as Pneumocystis carini. So, Pneumocystis jirovecii is the best answer here. It is not Mycobacterium tuberculosis or Coenobacterium diphtheriae or Streptococcus pyogenes. Okay. Moving ahead. A 9-year-old child presented with recurrent chest infections, greasy or loose bulky stool. So, recurrent chest infections or pneumonia is there. greasy, loose, bulky stool, and stool fat content is also high, that is suggestive of steatorrhea. So steatorrhea indicating fat malabsorption is there, recurrent respiratory infections is there. So this child probably has cystic fibrosis. Clinically, I would suspect cystic fibrosis in this child, even though the confirmatory investigations like sweat chloride or nasal transmembrane epithelial potential difference and all is not mentioned, or the gene mutation is not mentioned, but clinically I would suspect cystic fibrosis in this child. Okay, so moving ahead with our clinical diagnosis, let us try to answer the question based on the options given. So hypernatremia is common. Is hypernatremia common in cystic fibrosis? No. In cystic fibrosis, the sweat chloride is high. So sodium, a lot of sodium and chloride is lost in the sweat. In fact, the mothers may complain that there's a salty kiss of the baby of cystic fibrosis. That means when they kiss them, they can feel a salty taste because they have excess sweating. Excess amount of salt is lost through the sweat. As a result, they have hyponatremia. So much so that in summer days, it is recommended to give extra salt to them in the diet. So hyponatremia is common in cystic fibrosis and not hypernatremia. Okay, so this is wrong. Protein losing enteropathy is common. It is not so common in cystic fibrosis. It is mainly fat absorption that is impaired, and the fat soluble vitamins like A, D, E, K, they are mainly impaired. Even though sometimes protein losing enteropathy, loss of protein may be associated, but it is mainly fat which is lost. Okay, malabsorbed. Distal intestinal obstruction is common in this age group. So in a 9-year-old child, yes, distal intestinal obstruction syndrome is common. It can very much happen in this age group. In neonates with cystic fibrosis, remember, it is the delayed passage of meconium beyond 24 to 48 hours, or meconium ileus or meconium peritonitis that is common. But in older age group, you can have distal intestinal obstruction syndrome. So ileal obstruction can be there because of the inspissated secretions. So cystic fibrosis children can have distal intestinal obstruction syndrome even when they grow up. Okay. Rectal prolapse is a common complication of treatment? No. Rectal prolapse is one of the common features of cystic fibrosis that was seen previously in the days where treatment was not available. With the availability of pancreatic enzyme replacement therapy, that is the treatment being available, rectal prolapse is becoming lesser common in cystic fibrosis. So it is not a complication of treatment, but rather it is one of the manifestations of cystic fibrosis. So the best answer, which is a correct statement here, is distal intestinal obstruction is common in this age group. Okay. Moving ahead, a 12-year with history. So a 12-year-old child is there, history of recurrent infections and bleeding. Okay, recurrent infections is there, bleeding manifestations is there. On investigation, patient has pancytopenia and the peripheral smear shows macrocytes. The bone marrow examination showed no megakaryocytes and is filled with fat globules. What is your diagnosis? So the child is having recurrent infections. That means probably he may be having leukopenia or neutropenia. Bleeding manifestations, there may be thrombocytopenia, bleeding gums is there. So on investigation, we've been told that the patient has pancytopenia. Okay, that means the WBCs are reduced, the RBCs are reduced, the platelets are reduced. And peripheral smear shows macrocytes. Okay, so it is not microcytes, it is not normocytes, it is macrocytes. The bone marrow biopsy showed no megakaryocytes. That means it is a acellular marrow. Okay, acellular or hypocellular marrow is there, and marrow is mainly filled with fat globules. So this picture is consistent with a diagnosis of aplastic anemia. In aplastic anemia, remember, we get pancytopenia without hepatosplenomegaly or lymphadenopathy. Okay, so bone marrow normal elements will not be there. It will be hypocellular and replaced with fat globules. So aplastic anemia is the best answer here. In myelodysplasia or PNH, you get a cellular marrow. And ITP, you are going to get only thrombocytopenia. There will be no pancytopenia. Okay, so the best answer here is aplastic anemia. Moving to the next question, a 6-year-old child presents with hypertension. Moving on to the next question, a 6-year-old child presents with hypertension. On examination, the lower limb pulsation was feeble, very important, but the upper limb pulsation was normal. On chest X-ray, notching of ribs is noted. So what is your diagnosis here? So we are getting hypertension, we are getting the lower limb. So we are getting hypertension, lower limb pulses are feeble, but upper limb pulsation is normal, and notching of ribs. So this all points towards the diagnosis of coarctation of aorta. So in coarctation of aorta, hypertension is a very important feature, Difference between the upper and lower limb pulse is again very important. Upper limb pulses are normal in coarctation, but because of the narrowing, lesser blood goes to the descending aorta and the lower part of the body. So you can get feeble pulses in the lower limb or even absent pulses in the lower limb, like femoral, popliteal or dorsalis pedis pulses may be weak or absent in coarctation of aorta. And because of the formation of collaterals between the anterior and posterior intercostal arteries, you can also get notching of inferior margin of ribs in coarctation of aorta. Okay. So what we have here is a 34-week pregnant woman with polyhydramnios. Okay. And she has been given indomethacin. Which of the following can it lead to? So, indomethacin, if you give during pregnancy, it can cause cardiovascular problems, bleeding manifestations in the fetus, okay, and it can also lead to premature closure of ductus arteriosus. In fact, we give it as a treatment of patent ductus arteriosus in premature neonates, if you remember from what we have discussed in pediatric cardiology, right? And it can also increase the risk of necrotizing enterocolitis in the fetus. So many problems are possible, okay? So CVS, bleeding, renal problems, risk of NEC and premature closure of ductus arteriosus. So which of the following can it lead to? Patent ductus arteriosus? No, it would rather close the ductus arteriosus. So premature closure of ductus arteriosus? Yes, it can lead to that. Closure of patent foramen ovale or closure of fossa ovalis ASD? No. So the best answer out of the given options is premature closure of ductus arteriosus, although it does increase the risk of some other problems that we already mentioned. Okay. Moving ahead, a child with cyanosis has the following chest x-ray. So, a child has cyanosis and this chest x-ray, identify the diagnosis. Is it a cottage loaf heart and truncus arteriosus? No, it does not look like truncus arteriosus, though it does look like a cottage loaf heart. You know what a cottage loaf heart looks like? So, this is a cottage loaf. So, cottage loaf basically refers to, two pieces of buns are there kept on top of each other. So, what a cottage loaf is. So previously in olden days, cottage loaf was something, there were two pieces of bread, one was smaller than the other and the smaller bread was kept on top of the larger bread, like this. So it was a cottage loaf, okay. So this cottage loaf appears somewhat like the snowman appearance that we say. So like this, remember the snowman looks somewhat like this. So the upper circle is smaller and the lower one is bigger. Or it is also called the figure of 8 appearance. So this cottage loaf appearance or the snowman appearance or figure of 8 appearance, all these are seen in supracardiac TAPVC. It is not seen in truncus arteriosus. In truncus arteriosus, you can just get cardiomegaly with pulmonary plethora. But this cottage loaf heart is usually not seen in truncus arteriosus. Okay. So it is not this. Snowman sign supracardiac TAPVC. Yes, it does look like this. It has a snowman-like appearance, if you can imagine. See, right? Okay. Egg on side of TGA? No, it does not look on egg on side of TGA. What does egg on side look like? So, egg on side appearance looks somewhat like this. Okay, it appears like the cardiac shadow is just like an egg kept like this, egg on side appearance. And what about the boot-shaped heart in tetralogy of Fallot? What does that look like? So the boot-shaped heart in tetralogy of Fallot looks somewhat like this. Can you appreciate it? It is looking like a boot which is drawn in the picture alongside. So this is what classically you get in tetralogy of Fallot, boot-shaped heart or Corin-Sabet appearance with pulmonary oligemia. So that is also not the case in the picture given here. So the best answer here is snowman sign or that is seen in supracardiac TAPVC or total annulus pulmonary venous connection. Okay. So next what we have is which of the vessels carries deoxygenated blood back to placenta in fetal circulation. So in fetal circulation, the vessel which carries the most oxygenated blood or richest in oxygen is the umbilical vein. Okay. From umbilical vein we have discussed in detail. The saturation is 80%, then the blood goes to ductus venosus, then inferior vena cava, and then to the heart, and the organs like brain and heart get blood which is richer in oxygen, rest of the body gets blood which is poorer in oxygen. Finally, the umbilical arteries come out which carry deoxygenated blood which go back to the placenta for oxygenation. So, which of the vessels carries deoxygenated blood back to placenta in fetal circulation? So, it is umbilical artery and not umbilical vein. And remember, normally we have one umbilical vein is one and two umbilical arteries in the fetus. Okay. So I hope you've, in the pediatric cardiology videos, if you've not seen, just go through the fetal circulation once again. It will make things crystal clear in your mind. Okay. An infant presented with non-bilious projectile vomiting. So if you are getting a non-bilious projectile vomiting in an infant, okay, and some sort of constipation, you think of a condition that is congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. Okay. And in this condition, because the infant has so much of vomiting, a lot of chloride is lost through the vomiting. So in this condition, what you get is a hypochloremic alkalosis, because the gastric acid, hydrochloric acid, is lost in the vomiting. Okay. So you get a hypochloremic alkalosis. Okay. Hypochloremic alkalosis. There is no hyperkalemia. Okay. And this hyperchloremia is also not there. Hyperkalemia is not there. Right? The next question. What you have is a 9-year-old male who was brought to emergency by his mother with difficulty in swallowing for past few hours. He was noticed to play unsupervised and X-ray was taken to identify the location of foreign body. So what it looks like a coin or something, some sort of a disc-like thing, and the picture is such that the coin is lying flat like this. So if it is lying flat like this, it is probably in a structure which is, flat anteroposteriorly like the esophagus. If it would have been in trachea, it would have been like this, transverse. Okay, so like this in the anteroposterior direction. But it is lying like this, so it appears to be a coin which is in the esophagus. Okay, moving ahead, a 10-year-old child. What you have is a 10-year-old child who presented with generalized edema. On investigation, his serum cholesterol level is elevated. It is 238 mg per dl. Urine protein is 3+, which is quite significant. Stool microscopy revealed oval fat bodies. That means again lipid-laden rich macrophages are there in the stool as well. What is the probable diagnosis? So this child has got generalized edema and has got massive proteinuria or nephrotic range proteinuria. His cholesterol is also elevated. Okay, so there is generalized edema. Then you have massive proteinuria, you have hyperlipidemia. So this is a case of nephrotic syndrome. It is not Goodpasture syndrome. You're not getting any bleeding manifestations or pulmonary involvement. Urine infection doesn't look like, because the child is otherwise does not have any symptoms of dysuria or burning micturition, frequency of micturition like urine infection or fever is there. Nephritic syndrome, you would have got high blood pressure, oliguria, cola colored urine, all this would have been there in nephritic syndrome, which is not there here. So the best answer out of the given options is nephrotic syndrome. Okay. A child with hydrocephalus. So you have a child with hydrocephalus or enlarged ventricles of the brain had underwent VP shunt or ventriculoperitoneal shunt. He developed fever and irritability. Okay. Fever and irritability. So this could be due to meningitis or shunt infection. Okay. CNS infection would lead normally to fever and irritability. A dose of acetaminophen or paracetamol was given for fever spikes. What is the next step? So if we are suspecting a meningitis, and in this case because a VP shunt is in C2, VP shunt infection is also possible, what would you do? Blood culture with CSF culture via LP. Why to do an invasive procedure like lumbar puncture when you already have the shunt? If you have ever seen a child who has VP shunt, you will see that the child has the shunt which you can see and even palpate at the neck region. So you can just puncture the shunt and take out some CSF with aseptic technique using a syringe and needle. No need to do the lumbar puncture in this child. Okay. So blood culture with CSF culture via lumbar puncture is not required. Blood culture with CSF culture via shunt, yes, it can be done. Radionuclide scan is not required. Neuroimaging again would give you features of shunt block, raised intracranial tension, but it would not really tell you with a lot of surety whether meningitis is not there or not. For that, the best thing is to do a CSF analysis. Okay. And in this case, it would be preferable to do it via VP shunt tap. Okay. And of course, you need to start antibiotics. A child presented with myoclonic jerks. So, there are myoclonic jerks and decreased performance in school. So, poor scholastic performance and myoclonic jerky movements are there. There is a history of fever at the age of 1 year with rash, which could have been measles. Okay. EEG shows birth suppression. Birth suppression is compatible with a diagnosis of SSPE. Okay. That is subacute sclerosing panencephalitis, which is a long-term complication of measles. Subacute sclerosing panencephalitis, a long-term complication of measles, where you get myoclonic jerks, you get poor school performance, a rapidly downhill course, it is a neurodegenerative disorder, and there is a history of fever and rash is there in this child. Measles like history is there. Immunization history has not been mentioned. It is usually seen in unimmunized individuals. EEG shows burst suppression that again favors the diagnosis of subacute sclerosing panencephalitis. To diagnose this condition, what we do is we send the measles antibody levels, measles IgG levels in blood as well as CSF. Okay, so that is the investigation that should be done here. MRI brain for temporal sclerosis would not really help much in this case. Electromyography again would not have a role. Anti-GQ1B antibody in CSF you would do in Guillain-Barré syndrome cases or Miller-Fisher syndrome where you're suspecting, but that is not the case here. So measles IgG is the best answer. Okay. Moving on to the next question. A 6-year-old female presented with joint deformities. So 6-year female is there who presented with joint deformities and she has received multiple courses of vitamin D. So joint deformities, multiple courses of vitamin D she has received with no improvement. Her lab values are calcium is you can see 9.5 which is normal. Phosphorus is low 1.6. Alkaline phosphatase level it is elevated that is 814 international units per liter. However, the parathormone level is normal, electrolytes are normal, creatinine is normal. What is the diagnosis? So this appears to be a case of rickets, okay, because joint deformities are there in a 6-year-old child and she has also received vitamin D. That means someone would have done an X-ray and would have seen the features of rickets in there. Okay, and the most common cause of rickets is nutritional, that is vitamin D deficiency. So she has been given vitamin D, but there has been no improvement. That means probably there is some other underlying cause for rickets, and we know rickets can have a lot of causes like vitamin D deficiency, calcium deficiency, phosphate deficiency, renal causes and so on. So is it vitamin D dependent rickets type 1? So in vitamin D dependent rickets type 1, it should have improved with, giving of vitamin D. Okay, vitamin D treatment would have improved this condition. Okay, but this condition is not improving. Then is it VDDR type 2? VDDR type 2, you would not get normal calcium. Okay, and you would also not get normal serum parathormone. Parathormone would also be somewhat increased. Okay, because vitamin D, even though it would have been present, it would not have been able to act. And because of that, you would have got maybe compensatory hyperparathyroidism would have been there. The calcium levels would have been low. Hypophosphatemic rickets, yes, that is possible here because the phosphorus level is quite low. It is 1.6 milligram per dl. Normally, it would be like 3.5 milligram per dl to 5.5 milligram per dl or so on. Chronic renal failure, no, in chronic renal failure, you would get rather the phosphates would be elevated and creatinine values would also be elevated, right? So the best answer out of the given options here is hypophosphatemic rickets. Okay. Moving on to the last question that I've got here. A 10-year-old child presents with limb pain. So you have a 10-year-old child with limb pain and normal bone mineral density. Its X-ray is given below. What is the diagnosis? Is it rickets, scurvy or metaphyseal dysplasia or osteopetrosis? So what all do you see here? Can you see there is a pencil thin outline of cortex? It appears someone has drawn the outline of cortex using a pencil, you can see. Then what you have here is irregularity here, which is called, so irregularity is there, okay, and there is a white line here. So this is called white line of Frankel, and the irregularity, the black area is called Trummerfeld zone. The thing which is projecting here is called Pelton spurs. Then you have a ring-shaped epiphysis. So epiphysis you can see as if someone has drawn the outline like this, ring-like epiphysis, that is called Wimberger sign. And the limb pain. All these are features of scurvy, okay. So I'll show you one more typical X-ray of what scurvy looks like. So this is the picture that we have already got here. Okay. So scurvy you can see. So let us see the X-ray features. We'll zoom it and see the X-ray features once again. So what we said is pencil thin outline of cortex. So pencil thin outline of the cortex of the bone is there. We have discussed it in detail in the musculoskeletal video. You can have subperiosteal hemorrhages. You can have subperiosteal hemorrhages here, which can be dumbbell-shaped swellings, which are not seen in this case. What you have here is a white line that is called the white line of Frankel. Okay, the white line of Frankel you can get. Then the black area that you just see just near it is called the Trummerfeld zone. Okay, the black line that you see here, the black translucent area or radiolucent area is called the Trummerfeld zone. Trummerfeld zone, okay, and then you see the projections here, which is known as Pelton spurs, okay, Pelton spurs. And the ring-like epiphysis is called ring sign or Wimberger sign. Okay, Wimberger sign. So all these are features, radiological features of scurvy. And because of the painful subperiosteal hemorrhage involving the long bones, you get limb pains, and it is very, very painful to touch. The child cries when you touch the lower limbs, and the child would not want to move his lower limbs because of the pain. So that is why it is called painful pseudo paralysis. That means actually there is no paralysis, but because of the pain he is not moving his limbs. Okay. Now the x-ray in a child with rickets look like this. You can see that there is cupping or concavity, fraying or irregularity, and splaying or spreading of the ends of the long bones. So in rickets you have cupping, typically cupping, fraying and splaying of the ends of the long bones like you see in this x-ray. Okay, so that is what you get in rickets. Now what you see here, can you see there's some abnormality, some cystic shadows and some irregularity in the metaphyseal area. So this is what you get in metaphyseal dysplasia. Okay, metaphyseal dysplasia, abnormality in the metaphysis, some cystic areas, some radiolucent areas, irregularity, metaphyseal dysplasia. And what you get here, what can you appreciate at a first glance is there is increased density of the bones. The bones are appearing more white. Okay, so there is increased density of the bones. The bones are appearing more white than normal. So increased density of bones. And what else you can see here is a bone and a bone appearance. It appears as if a small femur is there inside the big femur. A small pelvic bone is there inside a bigger bone. So here also a small tibia inside another tibia. So bone within a bone appearance. Bone within a bone appearance and increased density of bones. So that is typical of what you get in osteopetrosis. Okay, osteopetrosis. So coming back to our question. So the given x-ray is compatible with a diagnosis of scurvy and the clinical features also. Rickets, we saw the x-ray. It is like cupping, fraying and splaying of long bones. Metaphyseal dysplasia, we saw some irregularities, cystic shadows and abnormality in the metaphyseal area alone would be there. And osteopetrosis, we saw there would be increased density of the bones with a bone in bone appearance. So these are some very, very important topics and these questions that came from pediatrics, though very much clinical oriented. But if you've gone through all the videos and including the rapid revision, image-based sections and the previous year's questions, I'm sure you would have been able to answer all these questions correctly. Okay, and I'm sure you'll get the specialty of your choice. Keep working hard, revise the important topics very well, keep your basics strong, and I'm sure you'll excel in all the exams that you appear for. All the very best.